Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, The Magnitude of Trastuzumab Benefit in Patients with HER2-Positive Invasive Lobular Breast Carcinoma by Otto Metzger-Filho et al. My name is Christina Harold, and I am an instructor of medicine at Harvard Medical School and an attending physician at Beth Israel Deaconess Medical Center in Boston, Massachusetts. My medical oncology specialty is breast cancer. The Herceptin Adjuvant Trial, HERA, randomized over 5,000 women with early-stage HER2-positive breast cancer who had completed local regional therapy and at least 4 cycles of protocol-approved chemotherapy to one of 3 treatment arms: observation alone, adjuvant trastuzumab for 1 year, or adjuvant trastuzumab for 2 years. The present analysis includes the 3,400 patients who were randomized to either the observation arm or the 1-year trastuzumab arm with a median study follow-up of 4 years. The primary endpoint of HERA was disease-free survival, with site and time of DFS events and overall survival included as secondary endpoints. Regarding central review of pathology in HERA, central confirmation of HER2-positive status was required prior to randomization. For tumors tested locally for HER2 status by IHC, FISH analysis was not required if the centrally performed IHC confirmed HER2 overexpression. Both ER and PR were centrally tested via IHC and quantified using the ALLRED score. Of note, the histologic subtypes of invasive ductal carcinoma, IDC, and invasive lobular carcinoma, ILC, were defined locally without central pathology review. Furthermore, ILC variants were not captured in the study's case report forms. In the present analysis, the authors compared the magnitude of benefit of adjuvant trastuzumab therapy for patients with ILC compared to those with IDC. Comparisons between the subgroups included ER and PR expression by ALLRED score, degree of HER2 amplification by FISH copy number and types of first DFS events, and sites of first distant recurrences. To begin reviewing the results of this study, of the 3,400 women included in this analysis, 5.5% had ILC and 94.5% had IDC. In both groups, the randomization to the 2 treatment arms was balanced. There were significant differences in ER and PR status as well as HER2 amplification between the invasive lobular and invasive ductal subgroups. For comparison of hormone receptor expression by ALLRED score, central assessment of ER and PR was available for greater than 80% of both subgroups. For these comparisons, high ALLRED scores were more common for both ER and PR in the lobular cancers compared to the ductal cancers. Conversely, low ALLRED scores were more common for both ER and PR in the ductal cancers. For comparison of HER2 amplification by copy number, FISH results were available in close to 60% of both subgroups. Patients with IDC had higher rates of high HER2 copy number compared to patients with ILC. Lower rates of HER2 copy number were more common in the ILC subgroup. Regarding survival benefits associated with adjuvant trastuzumab, there were no differences for patients with ILC compared to those with IDC. In the total study population, 1 year of trastuzumab compared to observation was associated with improved disease-free survival with a statistically significant hazard ratio of 0.76. The number and type of first DFS events were similar between the treatment arms for both the invasive lobular and invasive ductal subgroups. Similarly, there were no significant differences between the sites of first distant recurrence. Furthermore, there was no significant difference in overall survival between the treatment arms. In this context, it is worth noting that the HERA survival analyses were based on intention to treat, and that the protocol was amended to allow crossover to trastuzumab due to a significant improvement in DFS at time of planned 1-year interim analysis. About half of study participants in the observation arm chose to cross over to receive trastuzumab. This high rate of elective crossover impacts the interpretation of the intention to treat analyses in that the benefit of adjuvant trastuzumab may be underestimated. A few general conclusions can be made based on the results of this analysis. First, the prevalence in HERA of patients with ILC, 5.5% of the study population, supports the assertion that tumors with lobular histology should be tested for HER2 status, as is recommended by ASCO-CAP guidelines. Finally, the major conclusion is that patients with HER2-positive ILC derive equal benefit from adjuvant trastuzumab as those with HER2-positive IDC. To put these conclusions in context, a hypothesis of the present analysis was that tumor histology might predict a different magnitude of benefit associated with adjuvant trastuzumab. While no such differential effect was observed, it is interesting to note that lobular histology may in fact predict superior relative effectiveness of adjuvant letrozole compared to tamoxifen. At the 2012 San Antonio Breast Cancer Symposium, Metzger-Filho presented results from the Big 198 trial, including a statistically non-significant result of improved overall survival favoring letrozole over tamoxifen for the ILC group compared to IDC. Although the effect of letrozole compared to tamoxifen on overall survival appeared to be more pronounced in the ILC group, the 95% confidence intervals were overlapping between these two groups, making it difficult to draw firm conclusions at the present time. Meanwhile, multiple reports from the neoadjuvant experience have indicated that ILC is less chemosensitive than IDC. A representative example is a review of the MD Anderson clinical trials database that included approximately 1,000 patients who were treated on 6 trials investigating neoadjuvant chemotherapy. In aggregate, patients with ILC were significantly less likely to achieve a pathologic complete response, defined in this series as no residual invasive cancer in the breast and axillary lymph nodes compared to patients with IDC. The rates of pathologic complete response were 3% and 15% respectively. However, interpretation of this pathologic outcome is complicated in that despite a lower rate of pathologic complete response, the patients with ILC demonstrated significantly superior recurrence-free and overall survival compared to their IDC counterparts. This observation may seem paradoxical, but is likely due in parts to both the generally more indolent nature of ILC as well as the sensitivity of ILC to endocrine therapy. One interesting question introduced but left unanswered by the present analysis is the clinical relevance of central review of histology. As mentioned, in HERA, histology was defined locally and without central review. Unlike hormone receptor status and HER2 status, for which there is data to indicate discordance between local and central assessment, there is no such data regarding central histology review to inform our understanding of the clinical relevance of this practice. While the results of the present analysis suggest that central review of histology would have been unlikely to influence survival analyses from HERA, it is possible that central review of histology could impact other key treatment decisions, such as the decision of whether or not to pursue neoadjuvant chemotherapy and the choice of tamoxifen or an aromatase inhibitor for adjuvant endocrine therapy. For these practical reasons, future research to define degree of concordance between local and central assessment of histology would be welcome. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.